Hey, Rick, we do have a quorum when you're ready.
Okay, great. We will get started. So thank you everybody for attending. We usually have a large group of people, so please type your name into the chat and whom you're with, and that helps with our minute taking. So, and my name is Rick Trelevin. I'm the chair of the Health Council, and so do we have any public comment? Okay, then if anybody from the public does join, please feel free to jump in. Board members, have you reviewed the action items and the consent agenda? And if so, can I have a motion to accept the action items and agenda and consent agenda?
So approved. So moved.
Second.
Okay, Linda motion, Tammy second. All in favor say aye. Aye.
Aye.
Aye.
Aye.
So Megan, I'm trying to sort through the Hollywood squares here. Who's doing the patient story?
So we've invited Casey Sadahiro, who's our mobile outreach coordinator.
Okay, there we go.
The story, and he is here with us today. And it's really his story to share.
Okay, Casey, take it away.
All right, can everybody hear me? So today our patient story at Mosaic is a couple that we met up in Redmond out off of East Antler, where we do a weekly pop-up site along with Jericho Road and Thrive and a few other organizations. So I'm just going to go ahead and read it. So it says, back in the early 2010s, when Ben's economy went down, work also went down, and Chris found himself without a job. A mill worker for 23 years, Chris could no longer pay his bills, and he and his wife Debbie lost their home. Desperate and without other options, they packed their possessions in a motorhome and moved to a makeshift camp on public land. 1 year bled into 2, and before they knew it, they had lived there for 7 years. Some of the people want to be there, said Chris. For us, we had no other choice. We were stranded in those woods. Mosaic's mobile clinic parked at the entrance to the site weekly, but Chris and Debbie's camp was far away and the trek was daunting. It wasn't until Debbie started developing foot ulcers so painful that she couldn't stand that they decided to seek help. Chris started riding his bike over to us to get checked out and tell us about Debbie, and it took us about 2 months before we were actually able to meet his wife. Chris's main motivation to coming for us was to keep up on Debbie's health concerns and be able to bring back supplies for her, which we were able to supply for them when he would come by us. But while there, we learned that he had a lot of his own health problems, which were only exacerbated by his making those trips to us on a regular basis. So we found out about his heart. It was in constant atrial fibrillation, and he was in danger of going into cardiac arrest. We, through that time, assisted him getting into the ER 3 times, and our PA on the mobile said that his situation was so dire that he needed emergency care. Once we got him stabilized, we started making plans to reach Debbie. So because of the size of the mobile van, which you guys can kind of see behind me in this picture here, we were unable to, it's not really 4-wheel drive capable to go out there into BLM land. So with the partnership that we had created with Jericho Road, they were able to have a volunteer drive deep into BLM land, pick Debbie up and bring her out to us on a regular basis. And along with that, we were able to bring out another provider that was a little more specialized within Mosaic and some of her concerns. So we were able to bring him out for a clinic to do a special 1-day appointment with them. But while we were able to do as much as we could medically, there's still lots of other concerns that they had. So we partnered with organizations such as REACH, Deschutes County, Band of Brothers, Fuse, and Central Oregon Veterans Outreach to help them find a permanent apartment. So over the process, we got them from living out in the BLM land, living in a safe parking at a local church here in Bend with Reach and Stacy Whitty. From there, they were able to go into a hotel, and then from there, they moved into their apartment, and Band of Brothers, Kovo, and everybody else kind of helped get them set up and going. I was also, I personally am an OHP enroller, so I was able to get them both signed up with OHP and keep that going for them. And they now attend regular appointments. They're able to go into our clinic, not as they're able to, and just kind of manage life how, we take advantage of it, but to them it was like they needed the additional support just to get there. And once they got there, we're continuing it on, so that way they know that it's not just you're on your own once you get there, which is kind of the biggest barrier we run into right now. Chris and Debbie's story is not, it's an amazing story for us, but it's not just a one-off. We routinely have patients, and I think right now I have 6 patients that I manage and that are going through different variations of stages of where Chris and Debbie are. Some are just getting ready to be willing to move in somewhere, some are asking for it actively, and some are actually getting ready to move into their place as soon as it becomes available. That's our story.
Rick, you're on mute, Rick.
Thank you very much, Casey. That was a good story. Any questions for Casey?
I just wanted to make a comment.
Yeah.
So Casey, I just wanted to say thank you for meeting our community members where they are and supporting them in a respectful and dignified and compassionate way. And I wanted to say thank you to you and your team. I suspect that it is not easy in, just seeing the level of need and keeping yourselves healthy and whole. And so I just wanted to say thank you for your efforts and for what you do. It matters, and not a lot separates any of us on this call from being in that situation. And so thank you for honoring those that are in need. And it's going to take that individualized attention to be able to really support individuals with what they need. And so I just wanted to say thank you from the bottom of my heart for what you're doing.
Thank you.
Thank you. Anything else? Thank you, Casey.
Now's your chance. I'm here, and you guys don't get to talk to me that often. So if you have questions, ask them over the mobile.
No, I actually drive by your bus every day when you're out at Redmond, so I get to see it all the time. It's great work. Great work.
I was going to say, we can't just tail you over when we're passing you, right, on 97. So thanks,
I am
Casey.
always waving at people. I appreciate the waves all the time. Patients on the side of the road wave when I drive by headed on 97, so I love it.
Okay, great. Thank you very much. Gwen Jones, you're up.
Thanks. So it's nice to be back again. 5 months ago, I came to you and talked to you about Real D data, and you all provided your demographic data through a survey. Today, I'm returning with a summary of your demographic information. So for the next 20 minutes, next slide, we're going to do a quick review of what Real D data is, how it was collected, and shared your demographic information back to you. Next and next. So Real D is simply an acronym for race, ethnicity, language, and disability, and it's a set of standardized data and questions. There's also ongoing work to standardize questions about sexual orientation and gender identity. And those are called SOGI, S-O-G-I, so sexual orientation and gender identity. So using data to reverse health inequities is a priority for the Oregon Health Authority and the state of Oregon. Next. Keep going. Extensive research has proven that collecting, analyzing, and responding to demographic data helps in the following ways. It helps identify and change the structural, social, and health barriers that have impacted people. It helps us all understand better the people that we work with and serve. It helps us create services to meet those needs and guides our investments to reduce health inequities. Next. And next. And we know that the Health Council purpose is grounded in building an equitable and integrated health ecosystem for all of Central Oregon and using data to help you do that. Next. It's also a key ingredient of your strategic plan outlined in a strategic direction that's identified as identifying and addressing inequities. So very specifically, even more detailed, collecting real D data helps the Health Council better understand who you're partnering with and who we're not, prioritize recruitment for future board members, demonstrate support for the tool to improve health inequities. It helps meet a business need to serve our changing region as our partner organizations seek funding and support. People are asking, who's on your board? What's going on? Next. And so part of your board strategic plan, we've been gradually collecting, analyzing, and reporting Health Council Real D data. This year in 2021, we've started with the CAC staff and the board of directors. In the next year, we're going to be moving on toward the broader partnerships and involvement with work groups and committees. Any questions so far? Well, drum roll, please. Next slide. Let's find out who we are. Let's move to your results. Go back one more. Thanks. So you completed a survey during your May board meeting. It included the Real D questions with additional information gathered that included sexual orientation, gender identity, age, and geographic representation. Each question was self-reported and with an option to decline to answer. Analysis and reporting followed best practices with regards to disaggregating data, and we consulted with our DEI consultant, Ignatius, who will be here in a few minutes, given the small sample size. So of the 16 board members, 13 folks completed the survey. And move on to the next one. Thanks. So I'm going to recommend, if you want to see how it compares regionally, that you check out the Central Oregon Health Data website for comparison data. But for today, we're going to talk about what all you shared. On here, when asked, how do you identify race, ethnicity, tribal affiliation, country of origin, or ancestry? We had 3 no responses that you'll see throughout the slides. And then 10 folks identified as white, 2 as Asian, and 1 as Hispanic or Latino, Latina, Latinx. Next. When asked what language or languages do you use at home, predominantly English, with a couple of folks using languages such as Spanish and Hindi in addition to English. Do you have any functional limitations? We had 12 folks say that they did not, and 1 individual said that they did. When asked, how do you describe your sexual orientation or sexual identity? All 13 folks identified themselves as straight or heterosexual. When asked, what is your gender? 6 folks identified themselves as being a man or male, and 7 as female or a woman. When looking at age groups, our predominant group was in the 36 to 55-year-old range with 8 people. 2 people were in the 55 to 64, and 3 in the 64 and over age range. And looking at geography of residence and work, the area that we live and work in, folks predominantly lived and worked in Deschutes, and we had a couple folks that lived or worked in the other counties of Crook and Jefferson counties. So we have a few minutes, so I wanted to check in and see what questions of clarity you might have about Real D, the collection, disaggregation, or the results that you saw.
Hey, this is Brad. Break the silence. It's just really clear to me that we got work to do to diversify the board and get better representation across the region and across these different, representative categories of identity. The question is, what are we going to do?
Great way to kick off the conversation, because my next question is what surprised you when you're looking at the data and the information that you saw? What surprised you?
I don't necessarily have a surprise, but it's not unlike something that we have come up at our own board at COIC, which is a 17-member board, and we are the recipient of board members. And so, as I look around the Brady Bunch box of people, we've set up a board that needs to be in certain types of organizations and in certain roles. And so it sort of unwinds this sort of even going back further into how are we engaging and supporting mentoring and growing up individuals into leadership positions that create more diverse opportunity and be able to. So I don't know if I can articulate it very well, but it's something that we're struggling with, is because we don't necessarily, as a health council, go out and select members as much as we are the recipient of them. And I struggle with that too on our own board. So I'm maybe just fanning the flame of Captain Obvious here, but it is sort of a unique makeup of a board that is different than maybe a traditional nonprofit board. So how do we work with that to achieve the goals that we're trying to achieve?
So what are some of the other factors that have impacted a board membership? We know things are written into legislation. I think that's what you're talking about, Tammy, and there's certain people who sit in those positions. What other factors have impacted that, even if we think back historically and through a different lens of how systems are built? I can call on folks.
I'll jump in. I think Tammy kind of hit on it well and kind of set the table for it in terms of the systems we have come into. Were very well developed for people who look like me. And I have excelled well through that system. It's come pretty easily for me, for the most part. And so what I appreciate in what Tammy said is we got to dig even deeper. We got to go back farther for those particular board seats that do speak to this institution, this entity. We're looking for this particular position. We don't have control over that, so come on over. What I would say in the group that worked, I guess is the governance group that worked on our bylaws, we did kind of see a distinction between two types of board members on this board. There are exactly those types that Tammy referred to, which is to say leaders in particular organizations, and we don't have control over that. But we have other board members as well, and I'm one of them, who are not called out in the legislation and could be people other than me. And I think of some of our CAC members and folks like that as well, or CAC representatives, community representatives, I'm trying to say, we do have some. So it's kind of we're kind of a unique board that way, that we do have some we don't have any control over, but we have others that we do. And so for the ones we don't, it's a bigger institutional systemic question. And for those we do, we do. And perhaps there's a conversation there.
I'd like to add into what Paul said. I think of it in terms of what can we do short term versus what can we do midterm and what can we do long term. So if I look at the composition of the board today, one of the surprises to me, I think, was that we have a couple more women than men. And thinking back 20, 25, 30 years ago, when we started talking about raising women up through the organization, you could look at the number of leadership or the gender composition of leadership as being reflective of some success in those efforts, even though proportionally we're not at 50% yet. But on this board, we are fortunate, I think, to have a positive result from that initiative, and it should continue. Now, with the emphasis on diversity, equity, and inclusion, we can, with the replacement of any of our non-legislatively mandated positions, we can look immediately to introduce diversity and equity in those appointed positions. And midterm, perhaps look at the positions that are elected, for example, is another place to impact, not immediately, but it starts now to impact in the future, whether we have more diverse candidates. And then long-term, maybe develop a strategy about how we can work with others to shift the communities so that more people of color or gender orientation rise to the top of leadership.
Gwen, one other surprise to me was not a single tribal member being on the council.
A lot of good reflections around the factors that have impacted how things are made up, where you do have flexibility, where there's flexibility short-term and long-term, and some pretty big absences in who's here. So as you look forward into the future as a board, what does this mean for you as an individual board member? And what does this mean for you as a collective board?
Gwen, I could just say something as my experience for referring to the tribes. I actually made a road trip to Warm Springs to invite people to be part of the Blue Mountain agreement, working on the forest up there. And because of that personal invitation, they actually have been taking part. And, you know, I think we can't overlook the personal touch and how important it is. And I see it in several groups that we don't have Warm Springs representation, and clearly we should. Hopefully, someone from the Confederate Tribes of the Umatilla is going to become the National Parks Director, and I think that's really outstanding. Someone from Oregon. So anyway, I'm hoping his confirmation, I think it's next week. So, but, you know, I think that personal touch does make a difference for them.
Nice. So what does it mean for you as an individual board member and as a collective board?
Well, it means we have work to do. An opportunity on the horizon. So, I mean, I think this, even looking at where we are, what's our baseline, is a step in the right direction. And so, you know, kudos to getting started, but I think it's making sure that we don't let go of the momentum. And, you know, sort of a check-in, do we all share the goal that this matters? And I would say it does. So I'll start there.
And I would just add that to the greatest extent possible, we go out of our way to identify non-traditional candidates for positions, get to know people in the community that are doing great things, and encourage and support and nurture their continued success, and keep them top of mind if and when we have an opening.
So I strongly support this whole discussion. I think just in my experience, when we've done this in my own organization, it changes the discussion. in ways you can't predict in advance. And often changes, that change is often very healthy because it gets us to get out of locked positions and standard way, our usual way of thinking about things and framing the problem. And so it has us frame the problem in a different way. So I think we need to build that in over time and as board, be opportunistic in working that as board positions open up. So fully support that. Anything else, Gwen?
Well, just thank you very much for reviewing the information and reflecting on a great conversation. And it sounds like there's lots of conversations happening individually and collectively, both as an organization and as a board of directors. So thanks for sharing your ideas, and those thoughts are going to help advance your purpose and strategic plan. And I see that Brad has a hands up, but I'm going to say thank you and turn the floor back to Rick to talk to Brad.
Brad.
Thanks, Gwen and Rick. So I just want to reiterate Tammy's question or comment and her question. Has the board made an agreement that this is a priority to diversify representation on the board? Does that exist? Do we have a diversity, equity, inclusion statement that kind of directs us in that way? So I've got that question. And then the other thing is we identified, I think at the combined meeting or at some point along the way, leading up to that combined CAC and board meeting, that I think it's the bylaws, if not the bylaws, some other documentation for the board says at least 2 consumer reps can be on the Health Council board. So that opens the door in my mind. We have 2, but we could have more. And I think that'd be good for the board.
Divya, is that a hand raise? You're on mute. So don't complain that I'm not listening.
No, I want to make sure that Brad's points heard, and if there's a discussion, and then I'll bring in my point after that.
Okay.
So if you will, I can speak to Brad's first question. Actually, I think I can speak to both of them. We are in the process of actually vetting diversity, equity, inclusion, and justice commitment statement for the board to take a look at in November. We're actually vetting it with all the committees and councils for which we are responsible for, making sure that we're hearing as many voices as possible. So that will be coming to the board in November. And it's a pretty powerful statement, and it will require some action. It's not going to be post this on the wall and call it done. So there are actually areas that are pretty provocative and strong stated. So I'm looking forward to it coming before this group. Brad, I think point well taken. Yes, the 2 consumer reps would be, of course, yourself and Linda, or community reps, excuse me. And there is always going to be the question of how many is too many board members where you become ineffective and just, there's just too many of us to get anything done, or too many of you perhaps to get anything done. I hope that speaks to your question. And if I do have the chair's permission to proceed, I will bridge this work to our next exercise.
So, Donna, we do have 2 people who had raised their hands.
So so sorry.
Respect that, Divya and then Linda.
Yeah, my only comment is as we go forward with this and we bring on board members of the diverse backgrounds that represent our community, I do think that the onus also falls on us to understand and educate ourselves on cultural competencies when it comes to communication that is in line with how communication is received and how ideas are shared. Otherwise, we would just have board members who will sit on the board, but we wouldn't be able to really tap into the level of expertise and the wealth of wisdom that they have. And it kind of speaks to what Patty was saying, which is culturally speaking, you know, sending an email to somebody and saying show up may not work, because that's just not how culturally they respond to communication. So I mean, I'm just, my only thing would be that as we get intentional behind this, we have a lot of learning to do in terms of our own understanding of how to set that board member up for success and for us to be able to tap into their expertise. And that requires for us to understand what is the best form of how to communicate.
I think that speaks to the onboarding piece as well, Divya. So well stated.
Linda.
What Donna said, so I don't need to speak anymore.
Sorry, Linda.
Okay, and Brad is putting out a concrete proposal of increasing community reps to 4.
From 2 to 4. So adding 2
to 4. I had to pull up the chat first before it went away before I could finish reading it. And to represent the identities we are missing. So what I would suggest with that, Brad, is that we give that to Donna to work to get to an official proposal and see what we can do. And this sounds like it's a topic for next month anyways. And so it may be good timing. So it's a good idea, and let's work that this month to get a formal proposal and get that. And see whether that's where we're going or not. Any other questions? Megan, you're off mute. So.
That might be a great topic for the governance committee. So we can not only think about increasing the members, but continue the discussion about how to continue to advance the makeup of our board. So it might be great to roll through that committee to support Donna.
That's where I placed it, Megan. Thank you. And thank you, Tammy.
Okay, thank you. And so Donna, you're next. Introduce our guest.
Yep. I just wanted to make a little bit of a bridge from Gwen to Ignatius this afternoon. You know, just reaffirming where we are organizationally, and again back to that commitment that will come to you at the November meeting. We've also have diversity, equity, inclusion, and justice stated in our strategic plan. It's throughout the RIP. And of course, by standing up the Central Oregon Diversity, Equity, and Inclusion Committee, I think 2 years ago now, we are continuing to build on our purpose statement, which Gwen brought to bear around, we exist to build an equitable and integrated health ecosystem. I think that these statements and intentions, we want to continue to bring opportunities to the board for growth and authentic learnings. Pacific Source had brought forward a training last year, if I'm not mistaken, of which we did not fare well in the survey that the board was to take, and we actually only had 25% penetration. I don't even know if you can call that penetration. We kind of glossed right past that training. So I had spoken with Trudy Townsend with Pacific Source, and we kind of brainstormed around what would be best for the board and how we could accomplish this, because it is a CCO 2.0 requirement, and it's also the right thing to do. So we decided that we would bring Ignatius Spow back. You may remember Ignatius. He's been to the board, I think, a couple of times now. And I'm really pleased that he's here to do this equity training. And without further ado, Ignatius, you can take it away.
Thanks, Donna. So as Donna said, you know, health equity is emerging as a priority, as I'll discuss. And in addition, there is this training requirement as part of the CCO 2.0 contract that we also want to meet. And so we're trying to combine those two objectives. Next slide. By really hopefully being of use to you, as Central Oregon Health Council board members, but also in your own capacities as leaders in the community and in your own organization. So what I'm going to do is do a brief overview and then facilitate a conversation with all of us to really continue some of the conversation about the Real D data and the diversity of the Central Oregon Health Council board itself, but also other ways in which the council as an organization can support health equity. So my objectives, the first three are more didactic, which is understanding how the Oregon Health Authority, OHA, has prioritized health equity, how the federal government, the new Biden-Harris administration, is also prioritizing health equity, to look specifically at some of the opportunities coming up to continue to advance health equity, and then to ultimately meet this requirement of training as well. Next. So let me start. I'm not sure that everybody has seen this. Governor Brown in August of 2021 issued a diversity, equity, and inclusion action plan for the state of Oregon. And the subtitle is a roadmap to racial equity and belonging. It's a pretty remarkable plan, I will say, as someone who's not an Oregonian, someone who works here in California, but also nationally, to have this kind of leadership from your governor and really set this message, which I don't expect you to read, but I would commend to you, which is a message to state government employees saying that equity is their responsibility and part of their public service as government employees is to understand and do what they can to advance equity. Next slide. So something that should be familiar to all of you, the Oregon Health Authority, and now ratified by the Oregon Health Policy Board, has adopted this definition of health equity. Again, probably the broadest and in many ways most advanced or progressive definitions of health equity that are out there, naming race and ethnicity, but also the other intersectional multiple identities that individuals have, and that equity is about racial equity, but it's also about advancing equity in these other issues and areas and among those populations and communities as well. And then really this operational definition of what is equity. It first of all is not something that any individual, any organization, any regional grouping can accomplish by itself, that it really requires a collective effort. It requires everybody to make their contribution and to push each other, frankly, in advancing equity. And then secondly, what does it look like? What would equity look like if we were to achieve it, is often a question that gets asked. And it's really about power and resources. And it's just in the same way that this is a leadership body, and you just had some conversations about how it has taken decades for women to reach a more equitable place in terms of leadership in health sector positions, so that they're also then reflective in a board like this. Unfortunately, we haven't had that same kind of push when it comes to racial equity, and we still have these gaping disparities in terms of who is represented among the leadership of health sector organizations when it comes to racial and ethnic groups. And then what it ultimately does is it's not just rearranging the chairs around the table and who's sitting around the table, but it's really changing the nature of that table, changing the nature of how that power is exercised, how those resources are distributed. And it's really about reconciling and then ultimately rectifying the injustices, the inequities that are perpetuated both intentionally and unintentionally as we move forward. And so this is a pretty broad definition. It's a lot of work, but it also ties, I think, nicely with the work and mission of this organization, which is to improve the health of the region, that you're not going to get to improvement of the Central Oregon area until you pay attention to equity, until you pay attention to those historic inequities and injustices that have to be undone. So how do we do that? Next slide. Many of you have seen this visual or some variation of it. The difference between equality and equity. Equality is everybody's given the same thing. And so obviously the taller child has more access than the child that is shorter. Equity says that we'll even out what people have and try to redress that so that that shorter child actually gets 2 boxes to stand on so that they can also see over the fence in a way that they couldn't before. But really, ultimately, we want to get rid of the boxes and we want to get rid of the fence. And liberation is about everybody's able to participate. Everybody has the same opportunities. Everybody has the same outcomes ultimately, not because of their economic position, not because of their race, not because of their gender, not because of where they live or where they grow up, but it's because we genuinely are a society, are a community in which the health and liberation and opportunity for all is actually manifested and achieved. And so that's the broader vision. Obviously, we're a long way from there, but that's where we want to go. Next slide. So because this council is focused so much on the regional health improvement plan, I also thought it was really important to bring in, you may not have looked at this for a while, but there is a state health improvement plan. There's a SHIP as well as your RIP. And the two are very much in sync with each other. But if you look at the current SHIP, there actually is a lot in there about the way they engage community to do that statewide community health needs assessment, but also in their priorities. And so I would commend that as another way that as you begin to start thinking about your next community needs assessment and cycle of how you might incorporate some of the lessons, some of the even methodologies that were used in the state health improvement plan to be thinking about how you're going to frame that work for you all moving forward. Next slide. And then to the Oregon Health Authority, which is the crux of what you do as OHA is not only the regulator, but also the purchaser through the Oregon Health Plan, and therefore the contractor with Pacific Source as your regional coordinated care organization. And so OHA is now very unapologetic, unequivocal about saying that their overall goal as an agency is to eliminate health inequities. They've got a very ambitious goal that I've told them I'm not sure they can achieve, which is that they're going to do that within 10 years. But they're setting out to actually operationalize that definition of health equity in everything they do. And this reminder that COVID highlighted those inequities and how those inequities play out in Oregon in a way, again, in a really stark way that nobody can deny. And so if anybody needs still to be convinced that this is important, they simply have to look at the COVID data and our experience with COVID to show what those inequities look like. Next slide. So what I found really fascinating, many of you, again, as leaders of your organizations, is really interested in policy. This was a very active legislative year. There were a lot of priorities put forward by the legislature that were enacted. There's billions of dollars of new money that's coming in various fashion, a huge bump up in money, for example, for the behavioral health workforce, lots of other support. But the way that OHA, true to its form of prioritizing equity as part of their strategic goal, is their report on what the legislature did centers on health equity. This is the way that the legislature in its legislation that affected OHA centers health equity. So I would, again, we'll share the slides, which has all the citations to these documents so you can reference them. And so again, OHA is trying to walk the talk here and actually frame what the legislature did and charged them with doing and gave them budget to do in an equity lens. And again, there's a really remarkable report when you look at it of where all those opportunities that the Oregon legislature provided to OHA and the resources it provided to OHA to do this. Next slide. And OHA itself has been really active on this front. So the Metrics and Scoring Committee, which actually recommends measures for the CCOs and does other recommendations of measures, but one of its most important tasks is to recommend the quality incentive measures for the CCOs, did a equity impact assessment of how those measures did or did not support equity. And this came out in May of this year and found that not very many of those measures were actually driving equity forward. And so they feel like they have to do more through the incentive measures. And so you're going to likely see that coming down the pipe in terms of how those incentive measures might prioritize equity even more. Next slide. And this is just hot off the press. The Healthcare Workforce Committee also went through a long process, did a lot of community engagement, talking to community partners that were not the usual suspects, not the OHSUs of the world, but also talked to community-based organizations, talked to community-based providers, and really said, how do we get, as we all know that there are huge pressures, especially after COVID, on the healthcare workforce. We're hearing that all over the place, that there are shortages, that we know where the gaps are. There's always been the geographic mismatches and the geographic-based shortages, let alone the shortages of diverse workforce in the healthcare sector. So how does, as the committee charged with recommending policies, but also importantly, scholarships, loan repayments, other programs to support the workforce and the pipeline and pathways moving forward, how do they make sure that equity is part of that work? And so they just presented this framework to the Health Policy Board that is also really remarkable of how they're going to shift the prioritization of all their programs to really support equity so that it's not just supporting bodies, but it's actually supporting diverse workers in those positions in the years to come. And that's going to be really, really critical. So these are just two examples of things that are happening. I'm also working closely with the Oregon Health Authority on diversifying its own committees. So apropos this discussion about your own board, what are the ways that they could do better in recruiting diverse members, how they can have more inclusive meeting practices. To Dr. Sharma's comment, it's not just, again, getting a diverse person in, but changing the way that you might hold your meeting to make it more inclusive, to make it more welcoming, to make sure that those diverse voices are actually elevated. And then finally, how do you move a committee, a board, a council to actually using equity tools? So using equity analysis, using these things like equity impact assessments to look at your work. Next slide. So one of your responsibilities as the governing body for the CCO is also to review, which you have done, the health equity plan that Pacific Source, as your regional CCO, has submitted to OHA as part of its CCO 2.0 contract. And again, your responsibility will be to make sure that they're progressing on those plans and making sure that you're providing the support that they need to make sure that they succeed in achieving the objectives laid out in their plans. A very comprehensive plan, both internal facing as well as external facing. And our Pacific Source friends can provide more details in our discussion. So clearly, next slide, one of those requirements is education and training for everybody. So Pacific Source is doing a lot of its own education and training of its own staff, but also of its provider network. And clearly, the governing board is also a really critical piece of that. So again, it's really a 360 view of education and training, and that's what we're doing in this session as well. Next slide. So then just a quick look forward, moving ahead. Many of you are following the ongoing conversation about the next Medicaid 1115 waiver. The first 1115 waiver was what really created the CCO model and allowed Oregon to do all the great things that it has. And so OHA, again, is very clear that number one in the waiver application is going to be advancing health equity. You're going to see that in the waiver concept that they're going to unveil the revised concept in November before they bring it to the Centers for Medicare and Medicaid Services for approval for implementation next year. Next slide. And so here's a way that they see, again, overarching goal is advancing health equity. That's going to be maximizing coverage through some really creative proposals of extending periods of enrollment for children and for adults, minimizing the transitions and churn, making sure that there's even more flexibility in spending on health equity. And then what's really going to be new and also directly relevant to the council is new ways to structure the investments regionally on health equity. Next slide. And so, and originally the idea was something called health equity zones, which nobody really liked. And now they're talking about a 3% investment return into the community that would be controlled by the community through something like the Health Council, with input from a community advisory council. Again, all the details will be fleshed out, but what this will mean is more dollars, more community control, and that's where, again, the council and the community advisory committee are going to be even more critical as you move forward. And given the strengths of those structures here in Central Oregon, you're going to be well positioned to really take advantage of these new requirements, but also these new opportunities to increase your impact in the community. Next slide. So then very quickly, I want to turn to the next preview, which is, or overview of where the federal government is going. And some of this is perhaps new or unknown to those of you who are much more focused regionally. But if you look at what's going on with this new administration, day one on Inauguration Day, an executive order that explicitly said this administration is going to advance racial equity and we're going to support underserved communities. They also did that day one by convening a health equity task force to look at COVID-19. That task force has been hard at work, trying to constantly adjust the federal government's response, whether it's vaccine rollout, whether it's making sure that hospitals are getting the resources that they need to deal with these surges. That equity is a lens that they're using throughout that federal government response. Next slide. And then pretty remarkable, the Centers for Disease Control and Prevention, beleaguered because of COVID-19, in the midst of all that, made a very bold declaration that racism is a driver of these inequities, and that unless we are able to talk about structural racism and institutional racism, we're not going to be able to undo or reduce those disparities. And so you will see some remarkable information, again, explicitly calling out racism and racial equity as topics of public health, and as a public health crisis or a public health issue. Those efforts to continue to declare racism as a public health crisis in Oregon will also continue as well. Next slide. And then really on the inside, for those of you who are watching this, there's new leadership at the Center for Medicare and Medicaid Innovation, which has driven a lot of value-based payment models, has driven the accountable care organization model that you all adapted in your CCO model. And looking, and here we go. From now on, and this is essentially an op-ed written by the leadership of the new Center for Medicare and Medicaid Innovation. And so I bolded in red, the Innovation Center will embed equity in every aspect of its models moving forward. And so again, we haven't seen a new model yet, and I know some inside information of some new models that are being cooked on at the center from contexts that I have there. But it's really exciting to see that this is going to be a focus. And so again, additional opportunities for Oregon, for Central Oregon, if some of these new models roll out, to participate in some of these additional models, which are always by application, either by the state or by individual providers and networks. And so again, you're really well positioned for that as that comes forward. And then the final couple of slides next, which many of you may not have focused on. Most of you are aware of the National Committee for Quality Assurance, which does the HEDIS quality measures, which accredits health plans, which also does the patient-centered medical home model. So those are less relevant in the Oregon context, but NCQA is making this bold statement, which it has never made before as an accreditation organization, that high quality care is equitable care and there's no quality without equity. And they're committed to building equity into all their programs, into all their accreditation. So they're about to roll out a new health equity accreditation that is based on their former distinction in multicultural healthcare program. It will apply to plans, to CCOs, to ACOs, to hospitals and health systems. And they're going to start those surveys that people are able to get at that accreditation beginning next year. I've been privileged to serve on an advisory group that's finalizing these standards. And so again, that's really, really exciting that an important stakeholder like NCQA is moving and putting its efforts behind this as well. Next. And then finally, I want to end on a sobering, but for me, a really, really hopeful note. So as we may or may not know, we have a lot to do at our own house. And in this case, it's the House of Medicine. And so the American Medical Association has always been the organization that represents doctors in this country. And several years ago, it issued a remarkable apology to African-American physicians, to Black physicians, and made that apology public on the stage of one of its annual conferences to the president of the National Medical Association, apologizing for the exclusion of Black physicians from the AMA, of that wrong that had been done, forcing those Black physicians not to be able to be licensed in many places, not to be able to have hospital privileges. And so it made that apology. And now in 2021, it has now unveiled an even bolder plan to embed racial justice and advance health equity within the organization. Next. And so this is the plan. This is how they're operationalizing it, that they're going to embed it in all their practices and policies. And again, they have a lot to do. As they were railing this out, there was this horrible op-ed that was published in one of their publications that should have never seen the light of day, which they had to withdraw. They fired the editor. And so again, they still make these mistakes. So that's not an easy thing, that they are going to, back to sharing power, they're going to reach out and look at who they can partner with, so that it isn't just always listening to the voices of physicians, but also of patients, of the communities that those physicians are serving. And that's a remarkable thing that they're committing themselves to. That it's in part of innovation, that they're going to move to prevention and the upstream determinants and drivers of health. And in this last piece, again, which I haven't seen in any other healthcare sector, but is part of the OHA definition, which is that they're committed to truth, to reconciliation, and to healing, and ultimately to transformation. So again, for a health organization to put out there that they're committed to racial healing, to use those terms together, I think is remarkable. And part of what the strategic plan and report is a litany, which is so painful to read, of the history of exclusion, the history of discrimination that the AMA perpetuated internally with its policies, with its exclusion of physicians of color, with its exclusion of LGBTQ healthcare professionals, with its disrespect of individuals with disabilities. And it calls all that out and says, this is our history, we have to share it, we have to own it, and now we have to make amends for it. And we have to heal and reach out to those communities and do better and do right by those communities. So it's a remarkable plan. Next slide. And then finally, I don't want to bore you with this, but it just shows you how long it's going to take. And so back to, there's some immediate things that they can do, but in the short term, but they're committed to do this over 5 years, over 10 years, over a long period of time. I really commend the strategic plan to you. And again, I'll share the slides with all those citations for you to look at if you need. So let me end with my overview and talking at you, and really invite your responses, your questions, and really to answer these questions. How are you seeing health equity show up in your organization and in your work? Are there other things that you're seeing in the ecosystem here in Oregon or nationally that you think are relevant, that the other board members should know about? And then what more topics, what has this presentation sort of stimulated in your thinking that you think would be good for the board to continue conversation with? So we can go to the next slide and open it up. So how is equity showing up? How could the Central Oregon Health Council advance health equity? And specifically for the board, what might be useful for you moving forward. I'll put those in the chat, but maybe we can go back to the screen of everybody and take down the slides so that we can see everybody. Any comments, reactions, questions? Yes, go ahead, Linda.
I'm going to ask a question that feels clunky to me. I, for one, am thrilled about the work that's being done. The presentation you gave, the conversation we had earlier about leadership, awareness, education, training. There's a gap for me. The data that we have talks about the outcomes and the evidence in terms of gender makeup. In general terms of, we understand there is inequity in the system. If I'm a private provider and I'm committed for all the right reasons to do my practice's share of improvement around equity beyond hiring people of color, is there a data collection system or any way that I can learn specifically what are the actions I could take in my small practice to impact the inequitable outcomes? And I don't know if that evidence is available today. If it is, I withdraw my question, but it seems for me there's a disconnect.
So let me suggest throwing that open to especially the providers on the board. I have an answer to that, Linda, myself, but I'm curious to see especially how the providers, Megan, Dr. Sharma, others might react to that question. Is there evidence that, again, at a practice level, you can make a difference, that you can sort of see those reductions in equities?
Oh, absolutely. I mean, I can tell you that while there aren't that many, I just even looking at African-American people in our community, the few patients that I have, the areas of discussion that we have, I frankly asked them, I said, how are you, any brown person who comes into my office, the first question I ask them is, how are you doing? It's hard being in this community. And the conversations that we have every single time, it's eye-opening, and it's and we can relate to in many ways. And so, this Black family, and they actually then brought the rest of their family to me. This was not part of why they came to visit, to have their appointment with me, but they were being threatened by the neighbors in our community. They were affluent people who felt insecure living here. And so our conversations are very different. And I think that it's easy for us to gloss over that and just look at their vitals and look at this. But if we don't actually ask them, how are you doing? How does it feel to be where you are, to be a minority in this community? What are the things that you worry about?
I think that there's also data you can look at by population to see if there are disparities across the populations. I think we can do a better job of that as a community. I think there's pockets of that data accessible to us that can drive interventions that are different by population, but I don't think we've done it at a full community level and together. And so it makes me think that, is there some opportunity with our CCO data that we could be looking at it differently and by population to inform targeted strategies. So it's possible, but I don't think we do as good of a job as we could going into the future. So that's a great call out, Linda.
But I also worry that while we wait around for some of that data, we can also kind of falsely live in this place where we think things are better than they really are. And I do think that sometimes the data doesn't show itself at a micro level in our community, but when we look across the country, yes, there's well-documented outcomes disparity, all of those things. I think what sometimes starts to happen is as you start to tease that out at a micro level, you it doesn't get highlighted. And so then we have this false sense of, okay, this is okay here.
So
Yeah, go ahead, Rick.
just want to add a couple of little data points. So coming home from vacation, driving into Madras on Sunday, someone had put up a sign on their farm, Black Cows Matter. That's a bad statement. And then when last summer, when there was a small little protest in Prineville, where I'm community mental health director for Black Lives Matter. The counter protest included two gentlemen on horseback with nooses, and they were carrying guns. And that's a statement. And so this is the stuff that happens in Central Oregon. And I would reiterate Divya's statement. I think I've often reflected it must be fairly stressful to be a Black person here in Central Oregon. And I think we also have a long history of trouble while you're driving while brown. So I've certainly heard that from many of our clients. So those are little data points for us to be aware of.
One thing, Ignatius, that was kind of coming up for me is I really like the AMA approach of being very explicit about the long history and using that to move into, what is the pathway to move out of that. And so I wonder for us, and if there's a role for the Health Council, like we have a very long history in Oregon, but very specifically also in Central Oregon, like really, really powerful impacts over generations. And so could the Health Council have a role of sort of a similar process of really being articulate about this history, and then what's our roadmap and very intentional ways to move out of this over time?
And I would say in some of the work that we did with the Central Oregon Health Council and with you at Mosaic, Megan, we're learning some of that history as well. And so there's not only villains in that history, but there are heroes in that history too that should also be lifted up, and heroes in that history. And so again, I think that would be a really rich way of making this very real, in the same way that you're sharing some real stories and experiences that are contemporary, but also lifting up that history as well. Great.
What I really appreciated, I think, out of your presentation, Ignatius, is your last slide on the logic model for change that really acknowledges that this is nothing we're going to be able to address overnight. And it goes back to the Real D presentation, and Linda brought it up, and several people mentioned, if we use the advancement of women in our profession, it took many, many years to get to the point where now on the board, they outnumber the men. I think we can't keep beating ourselves up and thinking that we're going to be able to solve this overnight. To your question about what is our organization doing to advance health equity and being part of Advantage being part of DentaQuest, which is a national organization, I really like their model of addressing this topic, because it's really more about raising awareness and having the leaders within the organization then take what they're getting from a raising the awareness session and then leading their own teams, and then having to come back and attest that we had this discussion with our team, and we led the discussion and gave them the opportunity to comment, what is their view of diversity, equity, and inclusion, and why do they feel excluded, or why do they feel included? And so, instead of assuming that the people that we work with in our organizations are empty vessels that we have to fill them up with all this information. It's acknowledging that they have a lot to contribute, and how can we help them raise awareness that this really is it's an issue within our organization, it's an issue within our geographic region, it's an issue within the state and the nation. So, again, coming back to the point, we've got to address it, but let's not beat ourselves up that we're not able to fix it overnight.
Thank you, Dr. Allen. So others, how are you seeing equity show up in your organizations? Anything to share about ways that you're trying to do that diversity, equity, and inclusion work within your organization? So Tammy?
Sure, I'd really appreciate what Gary just mentioned. And I think there is a lot that we can learn about, as a woman in a leadership role, and thinking back 20 years, 30 years, that, would have looked different. But I do hope that we share a sense of urgency that is maybe different than what we've experienced in the past, because the conversation that we're having, is one where people are dying. And, that sense of urgency, I hope, shifts the narrative a little bit differently. And what I love about this conversation is that it's going to take all of us. And I'm hearing that we all matter. And in this conversation of using our own voices where needed to be able to elevate and highlight this as a critical need. And so I just wanted to say that I think that sense of urgency is something I know that for our own organization, we're feeling that. And I want to give that as my feeling to the council as well, that I feel a sense of urgency here. I think some of the stigma that we are living within our communities about the individuals that we're talking about. I mean, what does our community look like, and what are the needs in the community? I think we have a sense of urgency of elevating that and removing the us and them. And I really feel that our council has a unique voice in that space of being able to add clarity and action to affecting change in that arena. So maybe more commentary. Thank you.
Thank you, Tammy. So others from other systems?
For St. Charles, I think it was about a year ago, our executive team wanted to do some more just group unpacking, again, at the executive level around discrimination, historical propagation of inequity. And it was cool because nobody, I at the time was the only person of color on the executive team at St. Charles. Subsequently, about 6 months ago, there's another person of color, but it was funny because nobody knew what we could do to start. And so I had suggested a book club. And so the book I recommended and chose was The Underground Railroad by Colin Whitehead. I don't know how many of you have read that, but just an extraordinary novel, right? Fiction, but yet based on so much personal experience. And, many of you know the people who are my peers on the executive team at St. Charles. And I think that across the board, that book hit them, but, some people are more nonfiction. And so it was an interesting learning for me. So the next book, again, I ended up picking it, which is an interesting, and I would just caution this group to reflect on that. Diversity, equity, kind of historical oppression work is not the work of brown people or Black people. It really needs to be the work of everyone, particularly those who have historically had privilege and power. But the second book I picked was, because I learned from my first cycle, my first experiment, was nonfiction. And I picked Michelle Alexander's The New Jim Crow. And I don't know how many of you have read that. It's pretty dense and hard to get through. But that book hit so many of my peers hard because they're more fact-based, right? They're more like, show me the evidence, show me the data, show me the proof. And if there is one book I could recommend to really show the evidence of historical, consistent inequity in American society, it would be The New Jim Crow. So pick it up if you have the opportunity. There's
Or
also
if
a
you just want to
documentary.
watch the
There's
other
a documentary that's more accessible. Yeah.
13.
So it opened up a really interesting space for St. Charles executive team, which I would say is very historically white and male, to really start having a dialogue around diversity, equity, and inclusion, to ease the way into historical discrimination that's harder to talk about and harder to, I think, get your head wrapped around. But we did a series of clinical connects that really talked about diversity as it shows up in the clinical setting, and some of our physician leaders engaged in that. And so that was very cool. And then we recently hired a diversity inclusion person on our human resources team to really try to understand, as we rebuild our workforce, as we all are, how do we ensure that we can create conditions for people of color who are lesbian, gay, bisexual, trans, of different socioeconomic status, gender identities, that they feel welcome? Because you can do all this work trying to recruit, but once you realize you're living in Central Oregon and it's not as welcoming as the initial Visit Bend advertisement might lead you to believe, that how do you create conditions to keep people? So that's one thing I wanted to share, Ignatius. The second thing is, how do you take care of people who are at the sharp end of dealing with racialized trauma? We recently had one of our new community members, Barry Washington, killed downtown in a very, it's going through the court systems, but anybody, I think, with any kind of understanding of Central Oregon dynamics, as well as the national kind of overlay of, white supremacy and weapons, can understand that something went down there that wasn't right. And when Barry was taken by ambulance to St. Charles Bend Emergency Department, there was a team that took care of him and essentially watched him die. Some of those people are people of color. There are people who are married to people of color. And there is really no space in Central Oregon to unpack all of that, right? And so just to know that people are carrying around, similar to what Divya said, people are carrying around a lot of trauma, a lot of micro and macro aggressions that really impact their daily mental health, right, Rick? Like their ability to live every day, let alone thrive. So I think it's so important to name this, to prepare our workforce, both as personal impact of race and racism, but homophobia, ableism, all of the elements that separate us, that we need to acknowledge that and try to heal and create a space where we can work through all of that. So that's what I wanted to share.
Thank you so much for sharing both that internal journey at St. Charles, but also reminding us of the Barry Washington incident of, the advantage and disadvantage of being a small community is that there are those ripple effects. It's not just on his family and his friends and his community, but those caregivers, as you said, who are in your institutions and in your organizations who are also impacted by that. So it's not just a news story or a headline, but it has that human impact. And thank you for that poignant and difficult reminder of how those impacts can traumatize communities and individuals. Any others who want to contribute? Brad, go ahead.
Yeah, just the one thing crossing my mind now is essentially what I see as inequity in our entire way that we approach healthcare and health. And a good example of that is preventative health care. We seem to poo-poo that in terms of how investments are made and put more investment into hospital care, clinic care, things that are, I don't know, formal, for lack of a better word, but things like traditional care in the Salvador, in the Latino community, the Salvador. We have a few folks here, a couple folks. Families will call them and because that's who they trust, that's who they relate to. But our system doesn't support that. Medicaid doesn't support that, as far as I know. But even chiropractic, acupuncture, things that are naturopathic doctors, homeopathic doctors. My naturopathic doctor is not on the list of people that I get to choose as my providers, my home health home, whatever it's called, under Pacific Source Insurance. That's not a choice for me. So it's built in, and that is an inequity that's built in. It's like if you don't choose the type of healthcare that is supported by health insurance or other supports, you're just left out on your own. So that's just another kind of example.
Thanks, Brad. So others want to weigh in? Justin?
I don't know if Justin's available. It's Commissioner Dare. I just wanted to say something. Commissioner Phil Henderson had an adopted Black son that went to Bend High. And honestly, I could not believe how he was treated at Bend High. I'm like, this, anyway, there were some really unfortunate stories that were shared with me. And I was truly shocked. So it's, yeah, we have a ways to go. Truly a long ways.
And that's a 1 degree of separation rule that, again, it's your colleague, right, that you're sitting with who has that family experience.
He was my colleague last year. Yeah. So anyway, but he, definitely the things that were said to him were truly unbelievable. So I hadn't really witnessed that kind of a treatment. My kids went to multicultural schools, lots of different kids. I mean, truly lots of different kids. It was fabulous. I was really glad that they had that experience. So, and I don't think anything was said like that when they were in high school.
So Justin, you came back on camera. Anything you want to add? All right, you might be frozen. So I want to sum up then, and obviously this is not the last conversation you're going to have about this, and actually go back to the graphic of equality, equity, and liberation. And I think one of the themes that I always take away from these conversations is we often have this mantra of we should treat everybody the same. But I think we've heard some stories here of sometimes we actually have to treat people differently. So when Dr. Sharma says she starts her visits with her Black patients or brown patients with, how are you doing, how's your life, before we jump into the exam and talk about clinical conditions, that again, those kinds of building trust, building relationships, checking in on people in different ways, I think are good reminders of how sometimes we really have to take into account that people's lived experiences, the way that people move around in the world are so different than our own. And if we don't put ourselves in their shoes and check ourselves, we're going to miss a lot of what's right there in front of us. And I think in order for us to get to that liberation, we have to learn those skills, those competencies, that curiosity, that inquiry of how we can advance all this work collectively together, both individually, organizationally, and then in a group like this as the Central Oregon Health Council. So I thank you for your time, your participation, encourage you to continue the conversation in other ways as you move forward. And we'll obviously continue to work with staff in the Diversity, Equity, and Inclusion Committee to try to support this work moving forward.
Well, I want to thank you, Ignatius. And on an encouraging note, maybe reflecting a bit of what Tammy had said earlier, I don't think we could have had this conversation in the same way 20 years ago. So there is some movement, not as much as one would like, but some movement. But thank you very much. I think we want to continue to have these conversations. And my observation also has been some of these structural problems are fascinating. I'm a clinical social worker, which has to be the most liberal, bleeding heart profession on the planet. And you know, the social work board makes it incredibly difficult to not be anything but privileged white person to get on it. You know, just barriers you have to jump over to get into it. So it's fascinating how this plays out and frustrating. So always good to question all of us. Thank you. Linda, we have a little piece on the governance committee. Linda, you're on mute.
Is that better?
Yep.
Okay, thanks. As we were reviewing the minutes from the August meeting, you'll recall that there was a lively discussion and follow-up when Iman came and shared what the COVID perspective was and the impact on not just the hospital, but on the system. And there was a request for how can the system work better together to address the immediate need. And during that conversation, there were several people along the way who asked the question, I'm not sure what the board's role is in this situation. And we did come up with a proposal. And then later, the decision was made not to pursue that recommendation. And we haven't had a chance to discuss it since then. And this is not to discuss it today and right now, but taking it from a governance perspective, I think good governance would be to review the questions that were asked. What is the board's role in this situation? Or if not in this situation, the next situation that will occur. And then the second one is that there's a perception that perhaps we're not as transparent with each other as we could be. And it raises a question for me about what does transparency really mean in terms of respect for each other as board members? Have we outlined what that is? So from a governance perspective, Donna and Rick and Dan and I have talked about it, and we really do believe it's almost a perfect case study for this board and the governance committee in particular to talk about those questions that were raised and to start to come back with the process back to the board next month. That might be a recommendation on in the next few, how do we go about identifying what's the board's role in this and what are the processes we could use now or in the future. And then to really get a clear sense of what transparency means to each of us and how can we be transparent with each other and not draw unnecessary or unwanted fire from others, not to draw attention to ourselves is the phrase I think Donna used. And so I opened that up for feedback. We have put it on the governance committee agenda for our meeting in 2 weeks. I would love to have any spontaneous reactions to it before we deliberate, but we do mean to come back at the next meeting, hopefully with a recommendation.
And I would just say, as board chair, I have welcomed this conversation, and a whole lot of my job as board chair is just as a facilitator is trying to make sure that we stay in our lane lines for the board. And so help in sorting out where the lane lines are is good as we swim down the swimming pool of life. So I welcome this discussion.
Linda, this is Megan. It might be helpful for the committee to also make sure that we're really clear around this or what the issue is as we look at the board's role too. I think that might be helpful for all of us, when you come back to the full board, so that we're really clear about what we're talking about and then what the solution or recommendation is.
Okay, any discussion about this? Okay, thank you. So Kathleen Hinman, I see you have joined us, and you are to be presenting about the Deschutes County Self-Insured Plan. So I'm quite interested in this. I've already sent this presentation to our HR department.
oh no, right? No. Thank you. First off, I want to say thank you for, I joined the meeting a little early and was lucky enough to listen to the conversation and presentation by Ignatius. So I really appreciate that, hearing that and kind of being able to soak in that conversation and everyone's perspective. So one, thank you for my timing on being able to receive that. My name is Kathleen Hinman. I'm the HR director here at Deschutes County, and we have just a little self-funded insurance plan that we thought we'd share with you. Was asked to provide some information on. And, self-insurance, let's see, we can go to the next slide, actually. We'll start there. It is a health plan in which the employer assumes a financial risk, I'll emphasize all, the administrative burden, or a lot of it, for providing healthcare benefits to the employees. That's kind of coming from an employer stance. I do recognize that there are self-insurance programs out there that are like, maybe union-based or sort of organizations that have come together. So there's different ones, but this is definitely from an employer standpoint. We have the self-insurance is where we essentially pay claims out of pocket, which, it varies, right? So our biweekly payments are essentially what our claims are. So it can really kind of fluctuate. And that there's risk that comes with that, right? It is different than paying just sort of a predetermined monthly premium to an insurance carrier for a fully insured plan. So there's definitely some differences there. That's really kind of what self-insurance is. We pay the bills as they come in. That's kind of how it goes. Next slide. So the good, self-insurance. Being self-insured, we're not subject to certain government regulations or all taxes and fees. There's some things that being self-insured you don't have to follow. And that generally relates to about a 2 to 3% savings in costs for us. We also have flexibility with plan design, opportunity to customize members' unique healthcare needs. And I think that that's kind of a big one for us. One example is that we'll do direct contracting for specialty services. We needed, someone needed a very specialized surgery, right? It was sort of an experimental surgery. UCLA was the only place actually in the entire West Coast, almost nation, that would do that. we were able to do direct contracting with them since they were out of our network. So we're able to really meet our members' needs there. And we have access to all of our plan data so that we really do use this to be more proactive in plan design. So we'll look at a lot of different reference points, different benchmarks to see, kind of where we can maybe impact behavior or impact plan design to impact behavior, so that we, can see the benefit of that through our either cost savings or plan design, increased care for our members. And that you only pay for the healthcare costs of your own employees. Often if you're in a fully insured group, you're sort of diluted in terms of your premiums may very well go and pay for the care and needs of other organizations. And so we really can focus the funds that we have on the needs of our employees. And then also that we, maintain control over the reserves and cash flow. So, this is beneficial for us. It is, we limit the profit or the risk margins that are paid to insurers. And especially, I think, given that we're a government entity, that's kind of a more, a more responsible way to address our funds, that we really hold on to those reserves and keep them as we need them and can manage that cash flow. Next slide. So the bad, I will not admit, is not every day that I love being a self-insured plan. I often do, but there are some definite pieces to be aware of in self-insurance. And one, it's the volatility for smaller organizations or certain demographics. With a good size pool, right? I mean, we all know what insurance is. You can definitely see spikes or large costs that can, frankly, bankrupt some organizations in terms of their self-insured plans. So it's not necessarily for everyone. I'll also admit that, as we kind of heard earlier, age and lifestyle affects the costs that go through this. And so we actually, being such a diverse employer, meaning that we have lots of different jobs that we do here, and therefore we hire lots of different people to do those jobs, we see kind of that risk sort of spread out, where we don't have just one type of population or age of population. We work with lots of different populations in terms of folks working with us. The exposure to the risk, that's a big one. Stop loss insurance, that's what we use. And that's really our stop loss that we use is a kind of a catastrophic insurance, right, for those high cost claims. And we need that. We definitely have the highest of most out there. In fact, as we've looked at kind of continuing to increase our stop loss levels, right? So anything above a certain dollar amount is paid for by our stop loss insurer. So we'll never pay above a certain dollar amount for a specific claim. We're actually to the top. We just had this conversation with our carrier, and they're not really interested in providing us with quotes any higher, and they say maybe you guys just need to be 100% insured by yourself. So most folks, hover around a lower number, and that actually is really helpful with self-insurance, because then you kind of have a known cost or a cap to what you're paying. Employer and employee contributions to the fund are earmarked. So, it's not necessarily a bank account. We have to be careful about the funding and how we're funding that reserve or the money that goes in to pay these bills, right? So we have contributions from our departments and then from our members on the plan, our employees, and that goes into the fund, and those funds then have to be used for the benefit of the plan. So we do have some requirements around that. There is an administrative burden. It definitely takes a village to run a self-insured plan. We've got, knowledgeable staff to oversee the plan and vendors. I actually joke sometimes that a self-insured benefit analyst job is actually to just manage vendors. We have lots of folks that we work with to help with compliance with the both the federal and state laws that come in and impact our plan. Next slide. So what does self-insurance look like at Deschutes County? So we're a self-funded government multi-employer plan. So we partnered way back in the day. Self-insurance, you were actually required to be partner with another employer to become self-insured. That has changed, that it can be a single employer now, but we still love our partnership with COIC and work closely with them on our plan. About 20% of government employers have self-funded plans like us, just kind of a reference pointer data there. Our stop loss insurance, as I mentioned, we have a $500,000 deductible. So if claims come in that are single claims come in that are above that, then our stop loss insurance will pay that. And of course, we pay a premium for that stop loss insurance. And that helps us to manage the excessive risk or those catastrophic claims. We built a pretty well-funded reserve to manage that risk. One of the reasons why we're able to have that high dollar deductible is because we have this reserve, and the reserve is sort of twofold. It helps us to kind of smooth department rates so that we don't see this huge fluctuation or react specific to the prior year's claims. That's really helped us. That's what that reserve does. How we built it, we've actually worked with 2 employers now in building, self-insurance here at Deschutes County started before me. And how they built their reserve is that the first 4 years of the plan, they charged 130% of the actual cost to the department, to fund the plan. And that's kind of, that's a little bit about how government does funding. But some employers will just set aside $2 million to start their plan or something like that, some dollar amount. And again, we have that team of partners to manage the plan. We have our third-party administrator who does our claims management. We actually don't manage the claims in-house. We do have that great partnership. We actually have a pharmacy benefit manager. We have our flexible spending account vendor. We have our employee assistance program vendor. We have a broker. And then we actually have an on-site clinic and pharmacy too. So we actually have lots of, folks who also have lots of folks working together to make sure that we have this sort of smooth running self-insured plan. Oftentimes folks on self-insurance will kind of check the market to see what would it cost for us to go and be fully insured. We actually haven't done that in a long time. It's not something that we're terribly interested in doing, going fully insured, but every once in a while we do check. And we use an actuary with a lot of our costs, and it's actually kind of a requirement of our plan. And they've estimated that it'd be about a 20 to 25% increase for us to move to become fully insured. So we like where we're at. Next slide. So our plan, we are managing our costs through plan design and administrative adjustments. And so we really kind of have 2 major levers in adjusting how much we spend on insurance, and that's either through plan design, what is included, what do we cover on our plan, and then administrative adjustments. And so we're constantly looking behind the scenes at those administrative adjustments to see what can we do to improve the costs, right? And one of them, these are a couple that we've done. We've changed our TPA, and what that does, that improved the claims oversight. So we worked with a TPA that really kind of looked at our claims more closely to make sure what's being paid is actually covered on our plan. And that kind of just helps with that. We also constantly are renegotiating contracts and stop loss contracts. A TPA, good question, is a third-party administrator. And so they're the ones who look at our claims and process all claims that come in. So every time a member on our plan goes to the doctor, that's a claim. And so that comes in, and we use a third-party administrator to process that claim. And then we get a bill from them to pay that claim. That's kind of there's a lot more that goes into it. So I apologize, any TPAs out there, if I've sort of minimalized what it is you do. Our let's see, our renewal limits. That's a big one. So, we actually put things in our contracts like this is a big one with our stop loss, that you can't increase our renewal rates by more than 45%, for instance. And that seems like a big number, but it's actually come into to be very helpful the last couple of years, because we've had a couple of stop loss claims that have been higher and our renewals would have been a lot larger. So we look at ways that we can, put items into our contracts to help us kind of address those costs. We implemented an on-site clinic and a pharmacy, and actually we've seen such success with that we changed the provider model. We did have, and I think it was a DO, but an MD-DO model with a PA, and the MD was 0.5, so half time. And we saw such, and we actually had an opportunity that provider ended up leaving, and we looked at bringing in 2 providers, full-time providers, and we're actually nearing capacity again. We do see a lot of utilization of our clinic and our pharmacy. And then we regularly review our demographic and claims data, and we invest in the outcomes and improve quality of life. And so we were really looking at the what the claims data can tell us. And here's kind of an example, and actually it was kind of interesting with the conversation that occurred earlier. A lot of folks, we wanted to move our emergency care. We want to make sure that care is happening in the right location, right? So if it's a true emergency, it should be going to the emergency room. If it's more of an urgent care or a doctor visit, or maybe if it's our clinic, right? We just want to make sure that it's happening appropriately. And what we looked at is making sure, sort of adjusting how the plan pays for services that go to the emergency care. So if you went to the emergency care and it wasn't an emergency room visit necessarily, there's a higher cost dollar. But what we wanted to make sure is we looked at what kind of claims are going to the emergency room, not just claims that go to the emergency room should be paid there. And what we realized is that there was a lot of utilization of folks going because of not being able to manage their asthma. And so then we worked with that population to do an education piece, and that happened through our pharmacy and our clinic, to work on, because it's scary if your 3-year-old can't breathe in the middle of the night. I get why you would get up and go to the emergency room, but there's actually a lot that can be done to provide care to that member and actually avoid that emergency room, which is actually best for everyone if it's not a necessary emergency room visit. So that actually saved us dollars and improved the quality of care for that member. Next slide. So as I mentioned, we have that on-site clinic and pharmacy. And why did we do that? Well, there's a lot of movement to see, savings, dollars, just dollar savings in having our own clinic and pharmacy. But we brought in this triple aim objective where we want to improve the overall health of employees, dependents, retirees, enhance patient experience of care, quality, access, and reliability, reduce or control our per capita, cost of care. And what we found, we actually brought in a third party to do a return on investment. Like, how is this doing? Are we seeing this triple aim with our clinic, our pharmacy, and our wellness actually being located in one building where there is, we're not a true medical home, but we sort of act in that model where a member can walk between those 3 locations, and all of those providers can work together on the outcome of that member. And what we found was that we saw improved disease management care in our clinic than those in the community. And people become very attached to the providers in our clinic. So we really do see a good ROI on this. And I mean, I have retirees who put their retirement out 2 years because they don't want to leave the clinic, right? They really like their doctor. They really like our pharmacist. So it's actually been a great retention tool too. Next slide. Okay, so I was asked, in hindsight, what would you have done differently? Can you think of anything that we could have done? And there's kind of 3 that come to mind. When we brought in our clinic and our, that's what the doc is, it's the Deschutes on-site clinic. We're real creative with our names, right? So it's the doc, and we have the pharmacy, the providers, and the wellness. We weren't as dramatic with our changes to like the emergency room or urgent care, like co-pays. And so we didn't see immediately the transition from folks kind of, not using those areas appropriately and moving utilization to the doc. We had to do it with different incentives. And I think that would have been a good time to approach that, right? Really looking at that more holistically. And then the other one is that we have, we have our employees pay cost share, and the employer pays a portion, the employee does, and we use one rate. And I think that we're probably going to need to look at that, because we have one rate for an individual on the plan, and then we have one rate for a full family. And this is actually one of those areas where, looking at equity, we may want to really kind of address this. And then implementing the initial reserve funding at a lower limit. We may have over reserved ourselves a little bit. We thought maybe the sky would be falling a little bit. And so we are actually actively using our reserves to smooth out our costs. So we're actually using our reserves to lower, or we're trying to use them up a little bit more, because we just don't need quite as much as we have at the moment. So let's see, next slide, which is just a thank you. And if there's any questions, I'd be happy to take those, or conversation here, feedback too.
I'd love to ask you a question, or a few. I'd love to catch up with you actually afterward, but because there's so much to unpack there. First, amazing presentation. Thank you. I think it demonstrates really, as the total cost of care continues to increase, everybody's gonna have to think of some innovative ways to do this for the non-Medicaid population. But did I hear you right? Did you say on the stop loss component that you've kind of capped out that the insurer I think that's a pretty scary future possibility, right? As the cost of care goes up, if that stop loss goes away, your plan isn't viable, right?
Right. I mean, I do know another employer that doesn't have a stop loss, and I just don't think that that's a place that we're willing to be.
It's pretty risky, right?
Yeah, it is. I think we're comfortable being where we are. When we look at our utilization, it isn't too much. It's just that we found through the years that we actually moved from about a $250,000 stop loss up to 400 and 500. And those were risky. I mean, that was a lot of, are we comfortable doing this? And when we look back at, we actually just did an analysis on this, and we found, what if we were at 500, or what if we were at 600 for the past 5 years? What would be the best? And what we found is 500 is right for us. So we may be okay. Yeah.
Yeah. Kind of following along that line, because the general theory in old stop loss was, if somebody got hit by a car or a train or something, but it's increasingly becoming cancer-based patients who have very expensive drugs associated with their treatment. So, it doesn't take but 10 people at a $400,000 total spend that doesn't touch the stop loss to destroy the entire package, correct?
Correct.
Yeah, so I've been talking about this for 3 years. I couldn't appreciate the presentation more, and I'd love to catch up with you and ask you some questions that are probably more pertinent to the way we do it. And just I'd love to see if you came up with the same solutions that we did. But yeah, I think it's probably the greatest potential for the next kind of collapse in the system. If the total cost of care continues to go the way it's going, there essentially will be no other plans that you can cost shift off on to pay for underutilized plans. And the large majority of that is, like you were just showing, emergency-based care that's unneeded, hospital-based care that's unneeded, things with facility fees and large charging at the top of market. And I think the way you demonstrated on-site utilization of your own clinics is tremendous. So thanks so much for the presentation. I really appreciate getting to hear about it.
Thank you.
Kathleen, Justin, that made me think about, for Senate Bill 889, how do self-funded plans have to live within the parameters of the cost growth cap? Do you know?
You know, I don't know off the top of my head, but I can find out.
Yeah, that would just be kind of curious.
This is where the having the village and our benefit broker and consultant really comes in handy.
Kathleen, it's Patty Adair, and I just want to thank you so much for doing the presentation today. You know how I said I really feel like it's such a great plan. COIC has been our original partner, and then just recently we brought in Black Butte Ranch, and of course we had to do all this cost analysis, how to bring them in and fairly, you know, for both sides. So anyway, so appreciate it, and just to see how it's stabilized. I mean, it is truly miraculous that it keeps pretty stable.
It's true. Thank you.
You keep looking at what we can do, and yeah, don't go to the emergency room unless you really need it.
Okay, I want to thank Patty for bringing Kathleen in. This was a very good presentation, and I think it's good to look into the weeds about how to control healthcare costs, because I think that's part of the name of the game here. So thank you, Kathleen. That was a great presentation.
Thank you. Thanks for the opportunity.
Ms. Berry, strategic plan update.
Thank you, Rick. All right. It looks like we're running a little behind, so I'll be pretty quick here. I just wanted to share a few updates. There are a couple of surveys coming your way, one that you have currently in your inbox and one that's coming in 2022. So the current survey that you have that was sent out a couple of weeks ago is a survey collecting board members' organization alignment with the Regional Health Improvement Plan. That survey is due end of day tomorrow, October 15th. So we would really love to see the feedback from that survey. If it's something that you haven't submitted yet, we would really appreciate getting that back from you. Governance will review the results of this survey and provide recommendations around those results at the November board meeting. And just to give a little context as to why we're doing this survey, I don't know if you can see this, but there are board member names on this document. And this document actually lives within our Regional Health Improvement Plan. And what these signatures actually are connected to is this letter. And in this letter, I've highlighted a section. So as the Central Oregon Health Council Board of Directors, we are committed to the following. So there are 4 things that those board members signed to: pursuing the priorities, goals, and strategies described in the Regional Health Improvement Plan, continuing to build systems of health that support these priorities and meet the needs of our region, aligning plans of our respective organizations with the priorities of the Regional Health Improvement Plan, and helping us to facilitate cross-sectoral partnerships to achieve these priorities. In addition, within the Health Council's strategic plan, there are some practical visions that we want to see our organization moving toward in the next 5 years. And the first 2, vibrant, healthy communities and sustainable multi-sector integration, has a number of components that are directly related to the Regional Health Improvement Plan. There is also a strategic direction, our actionable things within our strategic plan. It's called Demonstrating Effective Governance. And one of those key things is stewarding a really successful Regional Health Improvement Plan. In addition, we're going to provide a second survey that will go out in January. The survey is twofold. First, it will collect input on the Health Council's strategic plan as it pertains to the Central Oregon current state and environment. So this goes back to wanting to check in to make sure that our strategic plan is in fact on track and in alignment with where we are with our current state. Second, this survey will also collect information on the Health Council strategic plan and board member organization strategic plan, and seeing how these two documents might align. This information again will be reviewed by governance, and the results will be, recommendations will be provided at the February board meeting. Does anyone have any questions? Great, I will turn it back to Rick. Thank you.
Thank you, Rebecca. Very good. Donna, combine, you asked questions. Okay, so I can move on.
You're on it, Rick. You are on it. Hey, bringing everybody back to the September combined meeting that we had. I can tell you the feedback has actually been pretty much over the top and making us so happy here as staff to know that we really hit on something that I feel is actually going to pave the way, in a sense, back to that diversity, equity, and inclusion conversation we were having earlier, because we're going to use our partnership and the relationships that we already have and continue to be good listeners and good learners, and back to the cultural sensitivities that were mentioned before. And how do we build a cultural, linguistically appropriate relationship if we're not in relationship with other people? So one of the ways that, again, just so you know what you're staring at, this was the result of the poll that was taken in the combined meeting with both the CAC and the board about what was really meaningful and important to those bodies for the folks that were there. So we are looking at ways to operationalize this. And when we looked at the top priorities, one of the things that we wanted to do today, but just didn't happen, weren't quite ready, is to now have a member of the Community Advisory Council actually do our patient stories. So have the patients do stories. I know it's amazing, but amazingly simple, but it really having the voice of the customer, to quote one of our board members, I think will be really impactful. So we're looking for that moving forward in our board meetings. Secondly, starting next month, we will incorporate information on emerging issues as they're coming up through the CAC, the Community Advisory Council. Sometimes we'll actually use different CAC members, but oftentimes it may be Brad or Linda that bring these things forward, but keeping us again closer to actually what's happening with the patients that we serve. We're looking at a frequency of every 4 months for the CAC and the board to convene for a portion of their respective meetings. So it may be board members on the CAC members on the board, but we are going to schedule these every 4 months beginning in January. And the reason we picked January was because the retreat month will be May, and we'll bring the two bodies together. And in the retreat, we will be examining the strategic plan, looking at, okay, where are we in the 5-year plan? And I think we'll be starting year 3. So it's time to look at that again as a board, and also with the CAC's assistance to make sure that we are focusing on those things that actually matter to our patients as well. And then that would also make the next combined meeting to be in September, which is the normal combined meeting for the CAC. So finally, we're going to do a mid-year survey to see if we're actually hitting these priorities that the CAC and board have identified to be operationalized by the staff. So any questions around that? And of course, if something's not working, we want to be good listeners and make sure we make some changes, but this is kind of our plan out of the gate. Any questions about that? Brad, Linda, did I capture that appropriately so in your recollection?
Yeah, I think so. I just wanted to make sure that that's not not everything though, right? That's just the questions we pulled on. Yeah.
Right. This is just our starting point. And I think in conjunction with the other work that we'll bring up through governance, I think we've made a good beginning pathway, if you will.
Mm-hmm. Agreed.
Okay, any questions or comments? Okay. So the next thing is Triannual Rip Report. We're back on track, 5 minutes ahead, but I would prefer that we aim to be done with the report at 3:15 so that we have time for the executive session without running over to 3:30. So if the project managers can manage themselves with that, then that would be very helpful.
We should be able to do that.
Okay, thank you. So take it away.
All right, so we are going to give an update on the RIP work groups, as well as share how diversity, equity, inclusion is embedded in their work. And this work is continually evolving, and we'll share specifics of it throughout the presentation. So we use multiple tools to convene our broad and diverse partners. Two of our main tools are a structured participatory consensus building methodology. And this is developed by the Institute of Cultural Affairs for facilitation. And then the second one is a structured problem solving process, which is on your screen right now. And this is our process for building regional shared understanding of priorities, measures, root causes, and developing shared actions. The work groups decide on overarching strategies called strategic directions that guide their implementation activities. Each of the work group has strategic directions that embeds diversity, equity, inclusion in their approaches, and these are their strategic directions. So empowering all people and community through inclusive and collaborative partnerships, improving coordination and access to culturally responsive behavioral health care, partnering with underserved communities for equitable decision-making, formalizing diverse, welcoming approaches, operationalizing organizational DEI practices, and cultivating equity and inclusion in our communities.
Okay, hi everyone, this is Renee. I'm sorry for keeping my camera off, but my internet is having issues. So I'm hoping you'll hear me okay, but if I break up, please let me know. The 2020 to 2024 Regional Health Improvement Plan has increased focus on health equity. The Regional Health Assessment and the Community Health Data website provides some disaggregated data about health disparities among populations that guide the implementation activities of the Regional Health Improvement Plan. Making investments into the region is one way that the work groups implement the RIP. And these are some of the questions that work group partners use to build the requests for proposals. And these questions direct them to the data that supports prioritizing marginalized communities and populations. So these questions are: which specific populations of people are prioritized? Which data sources support this? What are some recommended partnerships that you want the applicant to consider? And which specific geographic regions are prioritized, for example, rural? Next slide. A new application was also developed for grants that are awarded through the current Regional Health Improvement Plan. Applicants are now required to address health equity in the application by providing information about real-day data collection, how they intend to address equity, and that communities being served by the project are involved in its planning and implementation. Next slide. The new scoring criteria used by work group partners to review applications also focuses on diversity, equity, and inclusion. Projects are given points for meeting the criteria. Some of the criteria in the scorecard includes strategies that meet the characteristic needs of the people being served. The people being served by the project are involved in planning and implementation. At least 50% of those served by the project are from communities with health disparities. and the project includes multicultural measurements. Next slide. Now we'd like to share the major projects each of the RIP work groups are working on. Implementation activities are specific actions the work groups are taking to achieve the future state measures and their equity components. Next slide. The Promote Enhanced Physical Health Across Communities work group has allocated $500,000 to increase youth fruit and vegetable consumption and physical activity by reducing financial barriers for marginalized youth. And these applications are in the process of being reviewed. They're also developing an RFP to increase integration between medical and dental providers for OHP patients. They're developing an RFP to create a regional coordinator position aimed at increasing collaboration between agencies to address sexually transmitted infections. And they're partnering with Substance and Alcohol Misuse Work Group to implement healthy retail in rural and marginalized communities across the region. Next slide. The Stable Housing and Supports Work Group has been busy this year addressing urgent needs related to housing and homelessness. Stable, safe, and affordable housing is a basic need, a human right, and a social determinant of health. The current state of housing in our region falls short of meeting the basic needs of many and ultimately negatively impacts their health and well-being. The Stable Housing and Supports Work Group has invested over $1 million so far into much needed resources and infrastructure. They invested $200,000 over 3 years to develop a regional housing council to address the housing crisis and homelessness. They invested $265,000 over 3 years into Fuse permanent supportive housing to address chronic homelessness and reduce the frequent use of emergency resources. And they invested over $600,000 over 3 years to enhance housing case management infrastructure to support the region's continuum of care. And recently they published a letter and media release encouraging Redmond city councilors to allocate a portion of the city's federal COVID-19 relief funding toward 2 shelter projects that would help alleviate rising unsheltered homelessness in the city.
For substance and alcohol misuse prevention and treatment, they're in the middle of reviewing a proposal to comprehensively assess key drivers of binge drinking among 18 to 34-year-olds. This would include using existing data and focus groups. Then the consultant would provide recommendations based on the analysis of the data with specific recommendations regarding options for reducing health disparities among key subpopulations. They're also exploring enhancing SBIRT within the clinics to address binge drinking, and they're seeking to collaborate with the QUIM work group. And keep in mind, SBIRT will be an incentivized QUIM in 2022. And as Renee mentioned, they are also partnering with the Physical Health RIP work group to implement healthy retail. And then lastly, they're releasing 2 RFPs to stabilize peer support services. The first one is to fund clinics and community organizations to sustain their peer services in the short term while looking at long-term sustainability. And then that second RFP is to hire a consultant to work with those funded organizations to increase their financial sustainability, as well as work with the work group to address larger system level issues. For Address Poverty, they've invested $427,000 in programs and initiatives to increase high school graduation rates among students who are economically disadvantaged across Central Oregon. They're developing an RFP to address urgent food insecurity needs in Central Oregon and coordinating with the regional CDC grant that addresses social determinants of health. And they released a multi-phase RFP to address barriers of families who are asset limited, income constrained, and employed. This project will conduct listening sessions to determine unique needs of different communities. And then the listening sessions will have special emphasis on housing and transportation. The results will inform diverse approaches for each community to improve outcomes and meet the future state measure. The Behavioral Health Increased Access and Coordination Work Group is currently reviewing a $500,000 proposal to develop and implement a method to measure timeliness and engagement of clients with specialty behavioral health providers when referred to primary care. The measure is designed to be seeking applications and proposals that the measure is culturally responsive, that the chosen applicant will partner with rural and Latino folks, and that the measure will be easily understood by people with diverse experiences within behavioral health services. They're developing a request for proposal to test and champion regionally coordinated use of a screening tool and method to measure appropriate level of follow-up. And then they are collaborating with the Behavioral Health Consortium to invest in developing a behavioral health pipeline for professionals, focusing on rural areas, as data has shown that they have the least amount of providers. And this includes the need to focus on recruiting people and developing people who accurately reflect the communities they live and work in. For example, this might mean recruiting efforts in Jefferson County with priorities on BIPOC students. The Upstream Prevention and Promotion of Individual Well-Being work group has invested $200,000 in community programs supporting letter name recognition and reading. The projects were required to serve economically disadvantaged and underserved kids as defined by the Oregon Department of Education. This additionally included rural communities and city neighborhoods that experience economic oppression. And projects needed to partner with and address the needs of those communities that experience barriers, demonstrate that they have engaged those priority populations, and that the work and projects be culturally and linguistically relevant for those populations. They've released a request for proposal to continue and expand the successful Ask Anything media campaign from the last RIP cycle. It supports planned pregnancy based on new data and disaggregated data. The prioritized audience is people aged 14 to 29 and their partners. Please take special note, I'm not saying women, people. People with incomes less than 200% of the federal poverty level and their partners, people cohabitating, people of color, and youth questioning their gender identity and their partners. There's also the new detail and nuance that's being requested, that the campaign reflect the cultural diversity and intersectionality of identity for all these folks that have been mentioned, and that it be bilingual and include Spanish. Finally, they are also have also released and extended the release date of a request for proposal to develop and fund a regional immunization quality improvement coordinator to support organizations throughout the region in their efforts to meet needs for 2-year-old immunizations. And this effort is tailored to support sites who provide immunizations, serving clients who are vaccine hesitant, children and families experiencing houselessness, live in rural communities or city neighborhoods that experience economic depression, as well as other populations that are marginalized. So let's transition to the financial aspect of these implementation activities. On this slide, you can see the total collective investment of all the work groups and the investment to date of each work group. If you look in the top right corner, it's looking at our 5-year budget for investing in the community. So in total, the work groups have invested a collective $2.2 million of their 5-year $12 million as of September. If you continue down the slide in the rainbow colors, you will see the investments broken down by each work group as of the end of September. Now, keep in mind that a lot of the RFPs and the requests for proposals that you've heard about are still open. They haven't been closed and haven't been awarded. So those funds have not been included in this budget yet. Next, and then looking at year to date for 2021, looking at the right side of the slide, the work groups have committed to investing a collective of $2.5 million each year, which breaks down and translates to about $500,000 a year per work group. As of September, they're just shy of $2 million. And with the additional projects that are open right now and planned for the winter, they are on track to meet their investment goals. And we'd like to welcome any questions.
Hey Gwen, this is Brad. Is there a list somewhere on the Health Council website that shows each recipient of the funding that comes from Health Council? Kind of like a foundation has a page where they show everybody they give grant to.
Mm-hmm.
Does that exist?
Yes, on our health data website, and I'm looking at Rebecca because she's more intimately knowledgeable of this, but we do highlight on our health data website a lot of the work that's been done by the organizations. Rebecca, would you like to add to that?
Brad, you asked a great question. We're kind of in the process of updating this. So I'll drop into the chat a link that shows the organizations that have current funded initiatives with us. And then I'll also share what Gwen is referring to, which shows a number of different stories of what we've learned from past funded initiatives. Moving forward, we're actually going to share in more detail our currently funded initiatives on the Central Oregon Health Data site. We're hoping to launch that later on this year.
Thanks, Rebecca. Thanks, Brad.
Anything else? Thank you, Gwen. And I just want to note that there's an incredible amount of activity going on in these work groups, and often not very visible to the members of this board because you're not sitting on those work groups in general, but it's a very fascinating and sometimes slow process, but it's bearing some fruit. So, there's a lot of very engaged people in this process. So thank you. Then,
can
yes.
I first I want to say thank you. That is an incredible amount of work, and often, we don't do the check-in. And so having a chance to actually see the success and see where the investments are being made in the community is so important to know, especially for our day-to-day work as well. I want to, we have a public health crisis on our hands right now. And in my mind, that is the unhoused that are, the number of individuals that are struggling with housing and the number of individuals who are unhoused actually is a route to the success for many of the outcomes that we're hoping to achieve, whether that's health outcomes or educational outcomes or individuals being able to engage the workforce or, worker productivity in general, being able to attract, retain. I wonder what our role is in that conversation in a greater way. And I just ask, I'm not coming with a plan. I'm not coming with, I've got it all mapped out, but it really is foundational to the success of many of the initiatives that we are investing in. And it is outpacing us in being able to even keep up with, tracking the growth, let alone get ahead of it to address it. And so I just want to put a bug in our ear for some CCOs in different parts of the state are engaging their communities in a different way, or maybe I should say that the nonprofit network is engaging their CCOs in a different way of coming up with ways to bill for services and be able to invest differently. And so I just wonder if there isn't a space for us to be thinking in a more strategic way about how we align our efforts to get to solving some of the issues that we are seeing in a more strategic fashion than sort of this, a little bit here, a little bit there. I don't want to minimize by any stretch, and that last part sounded sort of like I was. I don't want to minimize the efforts that are happening right now, but it is outpacing us at such a great way that we won't be able to achieve success for any of the initiatives, in my opinion, that we're investing in if we don't figure out how we get ahead of that. So I don't know if that's the right time to lay that out there, but thank you, Rick, for the opportunity to say that.
I think there's a lot to be said to that. You know, we've invested in the strategic plan, so in this process, so I'm not sure we want to jump quickly to a different pathway. But I think it's always good for us to question, does the pathway we took in better times still applicable to meeting the needs we have right now? So I'm not sure as a process about how we get there. We can talk to Donna about how we examine that. But a very good question. So,
Rick, you know, it might be interesting for us to learn about the ongoing efforts in other CCOs that are being tried, just for our own education information as we continue to think strategically about how we're going to address and, you know, ideally get ahead of this issue. But I agree with Tammy, it's like continuing to grow, and it's getting out of our ability to get our arms around, or it has gotten out of our ability. So I think learning from others would be great.
right, and Linda.
I agree completely with Megan and with Tammy. And before the council makes any policy changes or decisions about it, I think we should do that in the context and in partnership with the other people in the community working specifically in that direction, because what we think might be the best investment and the best use of our funds and our resources may not be really what's needed. So I think doing it in the context of others working and with more active information would be helpful.
So I see on the text that Rebecca Donnell can bring examples from other CCOs forward. And I think that would be very useful for us. And Tammy is happy to help set up the effort too. Any other proposals? I think the idea of really taking a look at what's happening elsewhere would be super wise of us.
Thank you.
Thank you, Tammy.
I can pull that ad hoc group together.
Okay, great. And then what I want to do is go to executive session, and this would be for all the board members. So if you're not a voting board member, I'm going to ask you to leave, as this will be around a personnel discussion.